Welcome to RUMC Connections. Women experience unique medical concerns throughout their lifetime, such as pregnancy, gynecologic conditions, pelvic floor disorders, menopause, that may require some specialized imaging and diagnostic testing. So today we are joined once again by Dr. Menon, our chair of radiology at RUMC, and we will discuss some of the interventional radiology services that are available for women. So thank you again for joining us.
You're welcome.
How would you say that interventional radiology has impacted women's health issues?
So women's health issues in general is a very wide area, a wide topic. There are certain areas in women's health that interventional radiology has been very involved with and has provided very good service to. I'll give you a few examples. Number one, as we talked about in our previous episode, is fibroids. Majority of the women suffer from fibroid disease. It's more prevalent in African Americans and most prevalent in Asian women, particularly Indian descent or South Asian descent. My mother had fibroid disease.
Interesting.
The other areas that we help is pelvic issues like pelvic congestion syndrome, or which are dilated veins in women's pelvises, kind of like varicoceles in men's, dilated venous dilatation in women's pelvic floors. This leads to a sense of heaviness, pain, and sometimes bleeding. And also can lead to infertilities. That leads me to the third area that we very frequently provide services to women is fertility issues. As you know, the women's fallopian tube sometimes gets blocked by mucus, by blood during regular menstrual cycles. And this prevents fertility. This prevents pregnancy because the egg has to travel from the ovary through the fallopian tube into the uterine canal for it to implant. And if the fallopian tubes are blocked, that transport or that transit does not happen. So interventional radiology very frequently get involved along with our obstetric partners. And then we do a diagnostic test, and sometimes with that diagnostic test can lead to therapeutic tests also. Three examples. There are many more, but these are three examples. Radiology in general is more involved in women's health, particularly in mammograms. There are specific recommendations for mammograms for women, particularly at the age of 40 and above. For the general population, there are specific guidelines for women who have a family history, particularly intimate family history of breast cancer, like their sibling or their mother, and the first relative, basically. And there are specific guidelines, and I would encourage our listeners to, if that is the case, then they have a conversation with their physicians to see what the guidelines are and then follow those guidelines. Again, breast cancer is one of those things which are preventable, which are screened, and earlier the detection, the better it is for the patient.
If a patient has a history of it in their family, the guidelines are you're supposed to start screening at 35. Is that what it is?
Sometimes you have to start screening early. Sometimes it depends upon when the first relative was diagnosed with cancer. The first relative, let's say your mother or sibling, was diagnosed with cancer very early on. Then the guidelines are specific to that age of your first relative being diagnosed with breast cancer.
Absolutely.
So I would have a conversation with the physician, your own physician, and then have a conversation with the mammographer, which RUMC has. RUMC has a dedicated breast center. It's available, and I would highly encourage our listeners to seek appointment there.
Absolutely. So what would you say, being that you just mentioned the breast center, we do offer, the annual mammograms, and they do a lot of diagnosing there. So if there are benign breast conditions or bone density testing being done, we do provide world-class care that's not worlds away. So could you discuss some of the benefits, like we were talking about earlier, with the MagSeed technology for women who are undergoing breast surgery?
Sure. Yeah, definitely. So let's step back a little bit. First of all, our breast institute or breast center is absolutely world class. It's in a house in a beautiful location in a beautiful building. Our mammographer is actually a ex trainee of RUMC. So she's a RUMC product. She went on to do a coveted fellowship in specifically in breast imaging, and then she's back. She's phenomenal. So I would not only she's phenomenal in her work, she's also a wonderful human being. So I would encourage you to seek her out. Her name is Dr. Dara Fideli. So the process is this: you undergo mammography first. It's a screening mammography, and then, if there is anything suspicious, you're called back for what is called the diagnostic process afterwards, in which you undergo ultrasound and maybe a few more rounds of radiographs that are taken. If a mass or a suspicious lesion is suspected, it undergoes biopsy. Now, if it's a benign lesion based on pathology, and obviously we follow it according to clinical protocols. If it's not a benign lesion, let's say it's a small cancerous lesion that was detected, and that's the whole point of this screening process, it's detected. In that case, what happens is that we have a consultation with the surgeon, and the surgeon maybe decide to do a lumpectomy. What the lumpectomy means is just taking out that area of diseased tissue, just the cancerous tissue. During surgery, how can the surgeon actually find that area, right? He doesn't have x-rays, and sometimes x-rays don't help. What usually happens is during the biopsy, the mammographer leaves a small clip in that area where the patient has been biopsied from. In addition to that, what MagSeed is a small device. It almost looks like a small cylinder. It's about 3 or 4 millimeters
Like a little
in
sprinkle.
length. Yes, exactly. And it's a magnet, essentially. The mammographer leaves that right at the center of the tumor.
Yeah.
During the surgery, what the surgeon does is it has a device which detects this magnet, and he knows exactly what to cut around, what to incise, and he does exactly that. So what that provides is it provides for a very specific area of incision. It's less invasive, it's more effective, and the recovery time is less because the incision is smaller, the pain is smaller, the recovery time is less, and there's less chances of infection or less chances of adverse side effects.
Yeah. And it sounds like this technology, like you said, it makes things so precise. And you were mentioning before, do you think that they'll start using it outside of the breast in other parts of the body?
So as of now, it has not been FDA approved to
Okay.
use it in other parts of the body, but potentially they can be involved in other parts of the body. If it's a very small tumor in the liver or if it's a very small tumor in the kidney, it might help. In some occasions, it might help to put a small seed in there. Let's say, for instance, in the lung, a small seed in there, and it might help the surgeon target the surgeon's incision towards that particularly small tumor.
Okay.
So yes, it potentially could be, but as of now, the FDA does not approve of using this particular device in anything other than breast.
Okay. Let's talk a little bit about interventional radiology changing the standard of patient care for women and the role of it in gynecology, like you were touching on before.
So interventional radiology is one of the armaments that you have in women's health. It's not the only one. It's not, obviously, surgery is one, medication is one, conservative treatment is one. And it should be viewed as sort of a four-prong approach to all decision-making, all clinical decision-making. And I think it depends on, we will depend on the physicians, the primary care physicians, the OBGYNs, to use that. And we work with them all the time, and the more we work in multidisciplinary groups, we learn more about each other and about our specialties. And so as we grow forward and as we mature in our organizations, and I think those four-prong approaches will be used for most women's healthcare.
Okay. And can you touch a little bit again on how you treat the uterine fibroids? with the radiology?
Sure. So uterine fibroids are benign tumors that grow in the muscle of the uterus. It causes a lot of bleeding, causes pain, causes infertility, causes anemia because of the bleeding. There are 4 ways to treat them. One is conservative. Generally, what happens is, women reach menopause around the age of 50. Menopause leads to less hormonal stimulations. These tumors are actually stimulated by hormones. And every menstrual cycle, when the hormonal stimulation goes up, these tissues tend to bleed. And hence, you have excessive bleeding, you have breakthrough bleedings, and you have pain, and you have infertility. After menopause, the hormonal stimulation goes down, and hence these tumors tend to shrink on their own. So that's what I mean when I say conservative treatment. Before menopause, you can treat them with medications to make your cycles more regular, sometimes contraceptive medications or depot shots. The third approach is surgery to take out the uterus or take out the fibroids themselves if they are accessible with a procedure called myomectomy. Obviously, taking out the uterus is hysterectomy. And the fourth approach is interventional radiology related approach, which is uterine fibroid embolization. What we do is we access the blood vessels that provide nourishment to these fibroids.
Got it.
Those are the same blood vessels that provide nourishment to the uterus. We inject little plastic beads, inert plastic beads, through those blood vessels into the uterus. And they preferentially go and sit close within the fibroids themselves. Because remember, every tumor needs nourishment. All nourishments come from blood vessels. Because these tumors have excessive amounts of blood vessels in them, hence you bleed, like I said before, the beads settle into these fibroids. Once the beads settle into the fibroids, they are devoid of nourishment. If they're devoid of nourishment, the fibroids shrink. For the most part, it takes about 3 to 6 months for the fibroids to shrink to their maximum. The fibroids shrink about 60 to 70%.
Wow.
So let's say you have a 10 centimeter fibroid, it'll go down to about 4 or 5 or 3 centimeters. Now, what are we looking for? We're not looking to take the fibroids out. What we're looking for is to give the patient symptomatic relief.
Yeah.
So the combination of shrinkage of the fibroids and less hormonal stimulation and probably medications essentially takes the symptoms out. I've had patients who come back and say, wow, I've never felt like this in a long time, because fibroids are sort of insidious. They grow over time. And when women come to me and they say, I've been suffering this for the last 15 years of my life. And then 6 months later, they come back and say, wow, this is fantastic.
Yeah.
It's available. This treatment is available. The treatment is very safe. I think we discussed in the previous episode that you come in the morning, you go home in the evening. The recovery time is at best a week, with the more critical time in the first 48 hours. But even then, all you feel mostly is a little bit of fever, a little malaise, a little fatigued. Stay at home, watch some Netflix those 2 days, and you should be fine.
That's true. Are there any interventional radiology techniques or methods that are used for endometriosis? Because I know that could be another very painful issue for women.
So endometriosis, not so much.
Not so much,
Not so
okay.
much. Endometriosis are these islands of tissue that
Yeah.
are in different parts of the body,
Yeah.
in the pelvis, which are, which again get hormonally stimulated. They are the inner lining of the endometrium, which have somehow found their way from the uterus to outside the uterus. And sometimes they can be within the uterus, but if they're not within the muscle of the uterus, they can be outside the uterus. And if they're outside the uterus, then I think surgery plays a better role in them. But what we provide in RUMC is imaging. MRI of the pelvis is considered a very, very good diagnostic tool to diagnose endometriosis.
Got it.
That is a service that we can provide, and we can provide to our primary care colleagues and our OBGYN colleagues.
Okay, perfect. And can you talk a little bit more about the pelvic congestion?
Yes. The pelvic congestion syndrome is in women is very similar to varicocele in men. Pelvic congestion is the condition where the veins of the pelvis are dilated, and it's seen after childbirth. During childbirth, because the uterus grows so much, it obviously needs a lot of nutrition, so it attracts a lot of veins and arteries towards it. Sometimes after childbirth, when the uterus goes back to its original size and shape, some of these dilated veins remain. Veins, remember, they do not have a mechanism like the arteries do.
Yeah.
Arteries have the heart. It's a pump. The heart is pumping and the blood is flowing through the arteries because of the pump. It's a mechanical device, essentially. Veins, on the other hand, they go back. They are the vessels that carry blood back from the organs into the lungs and then into the heart to be pumped out again. Veins don't have a pump. So veins are basically sent back based on muscle contractions and based on some valvular pushing. So if the valves don't function well, or if the veins are so dilated that their blood is pooling in an area, it leads to thrombus, it leads to infection, it leads to pain. So generally, pelvic congestion goes undiagnosed. Is treated when a patient undergoes CT scan or an MRI scan for a different reason, and all of a sudden we see the interpreting radiologist sees dilated veins in the patient's pelvis. Then the patient comes to us and says, "Oh, doc, I've been feeling a sense of heaviness. Every time I go to the bathroom, there's pain. There's pain during sexual activity." So we do the imaging again, or we look at the previously done imaging if it was done in a reasonably short period of time, and we say, "I think you have pelvic congestion syndrome." You look at the imaging and you look at the symptoms of the patient, you put two and two together, and then you come up with the diagnosis. In doing that, there are specific interventions that we can do to basically shrink those veins in the pelvis. We, again, using catheters and wires, we get access to those veins, and we inject sclerosant, or we inject and put in coils, little devices that can go into those veins and stay there. Those are inert. They can stay there for the rest of your life without you having any pain, any problem. You will not know that they were there. What that does is that coagulates the blood in the veins, hence rendering those veins ineffective.
Okay.
And eventually what happens is the body reabsorbs the blood, and the veins shrink. When the veins shrink, the symptoms go away. So that's what we're dealing with.
Wow. And I had never heard of this syndrome until you had mentioned it. So how many people are impacted by that?
Again, it's very underdiagnosed.
Yeah.
Again, it can lead to infertility. In men, for instance, varicoceles, I'm sure you've heard varicoceles in men, which are the dilated veins around the testicles. They can lead to infertility. And they're essentially a similar pathophysiology to this particular syndrome in women.
Okay.
So it's a pretty high rate where patients can get impacted.
And are you dealing with varicose veins in patients like the type that they get in their legs as well? Is that a commonly?
So again, varicose veins, pelvic congestion, they are part of the same sort of continuum of venous disease that we treat at RUMC. Yeah. Varicose veins happens to be in the legs. A lot of men and women who spend a lot of time standing, restaurant workers, people who are continuously on their feet for many hours during the day. Nurses, surgeons, they tend to get venous pooling. That means the veins are dilated because the blood is basically stagnant in those veins. The blood is not getting sent back. And there are specific ways to diagnose them. We use ultrasound to diagnose them, and there are specific ways to treat them. Interventional radiology is at the forefront of treating these veins in the legs. Now, venous disease in the legs can be devastating.
Yeah.
They can cause non-healing ulcers. They can cause, edema. They can cause pain. They can reduce mobility, especially for our older generation citizens of Staten Island. They have to understand that the less you move, the worse it is for you. From a general health perspective.
So movement is key.
Movement is absolutely key. Venous disease, arterial disease can hinder movement. And I always say that that's the beginning of the spiral downwards, is if you hinder movement, the healthcare goes down of that particular individual. Make sure you move around.
Yeah. And what about for people, you said like waitresses, nurses, doctors who are on their
Yeah.
feet? How can they take preventative measures?
So the preventative measures is actually quite simple. A lot of nurses, a lot of physicians who spend a lot of their time on their feet, they wear compression stockings or compression socks, where basically you're pressing on the muscles of your calf and of your thigh to essentially think about the veins as a toothpaste. If you don't press the toothpaste, it doesn't come out, right?
Yeah.
So the same thing like that. The veins, if the muscles are not pressing on the veins, the blood doesn't go back up. So there should be something. If you're standing on your 2 feet, walk around. Walking causes muscle contraction. Muscle contraction causes the veins to get squished. And as the veins are getting squished, the blood goes upstream. So this is particularly a problem if you're standing in one place. If you're walking around, it's much better. Surgeons, like for instance, if they are spending a lot of time standing in one place doing surgery, they very often will wear compression stockings. If you see bulging veins in your legs and your calves, I think the first step is to go see a physician and see if you can wear compression stockings and see if that helps.
Okay, that makes sense. And let's talk a little bit more about how you use interventional radiology to treat the blocked fallopian tubes for women.
Yes. So we talked about this, the blocked fallopian tubes. What we do is we take a look at the fallopian tubes under X-ray.
Okay.
We access the cervix. We put in a small catheter. It's not painful. It's a little crampy discomfort. We put in a small catheter and we inject a small amount of dye, 5 or 6 cc's of dye. And we see the dye going from the uterus into both the fallopian tubes. Okay. If the fallopian tubes are blocked, obviously the dye will not go into the tubes. What happens is, and very often, the process of injecting the dye itself creates a pressure. Remember, the fallopian tubes are not blocked because of some pathology. They're blocked because of mucus or blood cells, little blood cells that get stuck there. Just the process of injecting the dye sometimes opens this up.
Wow.
And very often, that is all that is needed to ensure fertility. Very commonly, women who come to us say that, hey, look, doctor, I've been trying for 2-3 years. It's not happening. So the doctor just wants to make sure that my fallopian tubes are open. And initially, the first few seconds, the fallopian tubes are not open. But then if I inject a little bit more with pressure, I would say more often than not, the fallopian tubes open up, and that's all you need. Every time that has happened, I've asked all my patients to name their firstborn after me.
That's so funny. Oh, that's great. Okay, so does the interventional radiology ever pose a risk that could cause infertility? Like, say you're dealing with the fibroid embolization and things like that.
That's a very good question. So fibroid embolization is generally done on women who are in their late 40s.
Okay, so past
childbearing age. There was some concern in the initial years of doing fibroid embolization of the theoretical risk of infertility. Since then, that risk has been debunked. That risk has been debunked, and that people have said that we've had kids, and I've had patients who have had kids after the embolization. So you don't have to live in pain, even if you're in your 30s.
Okay.
In your childbearing age, or even if you're in your 40s and you plan to have kids, you don't have to live in pain.
Okay.
So there are risks associated, but those risks in the literature have been debunked.
Got it. Okay. So I know we have the Breast and Imaging Center at 1161 Victory Boulevard. And for the gynecological issues, you would treat them at RUMC if you were doing any of these procedures in the hospital itself?
All interventional procedures are done at the hospital. And they're done at the hospital for 2 reasons. Number one is that's where we have our latest and greatest tools. We have the support of other specialties, and we can recover you and make sure everything's safe before we can let you go.
Okay.
We have a team of very, very experienced nurses. We have a team of experienced technologists who are part of our team in interventional radiology who have been doing this for years and years and years. They have fantastic experience. You'll see that when you come to us, we keep patients at the forefront. We make sure that the patients have a good experience. It's never a pleasant experience in a hospital, but we make it as pleasant as possible. Yes.
Okay. So there are certainly some very good, techniques that we can use the radiology for to address infertility and, really help these women, especially, with the fertility options like we talked about. Would you say that the procedures themselves far outweigh the risks in these?
So all procedures, whether it's interventional radiology procedures or surgery, all procedures have risks. But all procedures should also be done at the appropriate time to the appropriate person. Choosing the appropriate time and the person is the key thing. When somebody actually asked me this question, what makes a good doctor versus a not so good doctor? Answer to that was only two. One is how you come across to the patient, and number two is, are you doing the right thing for the right person at the right time? And sometimes it's a judgment thing, and I think that differentiates a good physician from a physician who's trying to get there. I don't think, I'll be a little biased here, I don't think there are any bad physicians, and I think some physicians are trying to get there, and some physicians inherently understand that. And I think we at RUMC are in a unique situation in which, of all the physicians that I've met at RUMC, nobody needs to get there. I think all of us, without exception, I'm telling you this without exception, and I've worked in 4 or 5 hospital systems in my career. Without exceptions, they keep patients at the forefront, and they want to make sure that they do the right thing for the right patient at the right time.
Absolutely. Couldn't have said it any better. Well, I would like to thank you once again for
You're
joining
welcome.
us and informing us about all of the radiological issues that we can receive services for at RUMC. And thank you once again for keeping us safe and healthy, Dr. Menon. That about does it for this episode of RUMC Connections. For more information about interventional radiology services, or if you'd like to schedule a consultation, please call 718-818-3280. Or to schedule a consult at our Comprehensive Breast and Imaging Center, you can do so by calling 718-818-1161. And all of the following information is at www.rumcsi.org. Thanks for joining us. I'm Meredith Gaskins.
Thank you very much. It was a great time.
Thank you.